So hopefully this will help you understand neuroplasticity and change your views of things and educate you as well. So do you want to just dim the lights slightly? You just switch the lights off, I guess, do you? Or is it? Okay, that's fine. I've got this one over here as well. So we'll get it started then, okay? So it's by Centis, and here we go.
Not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-travelled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep travelling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
Right, okay, so coming to the reason why I was originally invited to this meeting, it's based on a paper I did back in 2009. That was a culmination of many years of work looking at hypoadrenalism and its relevance to rheumatology and to a degree orthopedics. And you obviously know me already. So essentially, I was in a acute medicine meeting in the morning. We were having a handover, and it was announced that actually there's a global shortage of synapthin, and I just thought, fantastic. At last, hypoadrenalism has become on the headlines. But when I actually looked for this, I could only find one or two links on Google related to it, telling us what was going on and what was available and what wasn't available. So this is the article. It's 2009. You can get it through your library if you are interested. If you have access, for example, I have access through the Royal Society of Medicine, so I can use that access to actually get access to this journal, Clinical Rheumatology, which gives you the full paper with the full cases. I've only concentrated on two of the cases because both of those involved had orthopedic involvement. So in terms of the hypoadrenalism epidemiology, this is figures from up to date. The prevalence of chronic primary adrenal insufficiency in Europe has been doubled from 4 to 70 cases per million in the 1960s to 93 to 144 cases per million by the end of the last century and in recent years. The current estimated incidence is 4.4 to 6 new cases per million. So it's still relatively rare, and it's something you have to sort of exclude the diagnosis of exclusion. That's the reason why people have so many synaptin tests, presumably, and more so to try and see if they can pick it up. Primary adrenal insufficiency affects more frequently in women. Autoimmune causes account for 70 to 90% of cases, which I was quite surprised by. And this is from up to date, and I didn't cross-check the references. I'll hold my hands up for that. But and TB accounts for 7 to 20%. And if you consider that still a large part of the world is developing, I still feel perhaps those figures are perhaps too optimistic, and I suspect TB may still be a higher cause of hypoadrenalism. So it's estimated that the prevalence is about 150 to 280 per million, and more common in women than men. So anyway, the cases. So it's a sort of very clinically orientated discussion this. So it was a 49-year-old female who came to our hospital, which was the Wrighton Hospital in the Northwest, when I was a registrar back then. 2-year history of increasingly painful knees, occurred at rest and was associated with stiffness. And this affected her sleep and ability to have intercourse. She had orthopedic input 1 year previously, and there's nothing objective to find. But what they did find in their blood tests was abnormal liver function tests, and she had what was a non-functioning gallbladder that was removed. Incidentally, she also had T3 toxicosis that was associated with a worsening of her symptoms. Examination revealed left knee fixed flexion deformity, but no obvious evidence of arthritis or synovitis. And this is the time before radiology was being used in terms of MRIs, and ultrasound were being used extensively. This is back in 2003, 2002, 2003. So at that stage, it's still fairly early days for ultrasound and MRI of the musculoskeletal system. And her blood pressure was consistently below 100 millimeters of mercury. Further question revealed that she had 2 stone weight loss over 2 years despite maintaining a normal appetite and had been experiencing increasing fatigue. Investigations revealed a HB of 11.1. Gamma GT was raised at 89, which is the reflection of the abnormal liver function tests. The immunology screen was negative, and the x-rays of the hips, pardon the spelling error, and the knees showed evidence of osteoarthritis or erosive changes. Bearing in mind she's relatively young, she's 49, you know, she wasn't particularly overweight, so it's unlikely that's going to be a cause of her problems, especially if she was getting stiffness and there wasn't any problems with actual activity. So definitive test. So basically, because of the weight loss and the low blood pressure, it's felt something else is going on here. And they did a short synaptin test that was positive, and also a long synaptin test that was positive was found to be positive as well, interestingly. And it was felt by the endocrinologist that the reason why that was positive was because of the fact that she'd had been hypoadrenal for so long, so the response is going to be very flat. Case 2 is a 69-year-old gentleman with a 3-year history of worsening knee, hip and lower back pain. Now this chap's probably more in the osteoarthritis range compared to someone who's 49. Hip and knee pain was continuous, worsening in the cold and with walking, so it's very mechanical symptoms there that's going on with this patient, as opposed to our first patient that was more inflammatory. Lower back pain with standing, again, a mechanical problem, and limited flexion of the fingers, interestingly. Being seen by orthopedics again 1 year previously, who noted the fixed flexion deformities of his hips and knees and thoracic kyphosis. And the x-rays revealed, not surprisingly, on 69-year-old osteoarthritis, you'd expect in that age group anyway, because we'd all probably about that age have some degree of osteoarthritis in our joints as part of the aging process. He was treated with physiotherapy and steroid injections, and the orthopedics wondered if he had stiff man syndrome. So the neurologist said no and advised a rheumatology referral. Further history is listed, and it was noted that this gentleman had a coronary artery bypass graft some 20 years previously. And 15 years ago, he'd been diagnosed and treated for hypothyroidism, which was diagnosed at that stage. And interestingly, he'd been impotent since his coronary artery bypass graft. Now, I'm not sure if I remember his history correctly, but I think his wife may have left him at around that time. So, we found him to be a frail gentleman, normal blood pressure with no postural drop, musculoskeletal examination with a fixed flexion deformity of 30 degrees, and a compensatory knee flexion. Left-hand flexion was limited as well. Now, I've put in stress because obviously clearly there's something we do a lot in rheumatology, is examine the testicles and look for absent hair. It's clearly a very important rheumatological examination, I'm sure you'd agree. But so you do not do this without good evidence of suspicion of hypogonadism, okay? So that's what I'm stressing to you, is that if you suspect it, then you look for it. So you have good reason to look for it, hypogonadism. So that's something to bear in mind. So investigation revealed HB of 11.0. ALT this time was raised at 77 as opposed to the previous patient, as gamma GT was raised. Immunology screen was negative, but his pituitary function test gave us the answer with unmeasurable FSH, LH and TSH. Free T3 and free T4, that was quite low, with practically no TSH, and testosterone being low as well. X-rays confirmed evidence of generalized degeneration, and interestingly, hand ultrasound was normal, but I haven't got the images, and obviously at that stage it was relatively early, so compared to what we do these days, I don't know how good the images were at that stage. So a short synaptic test was done, which is positive, but in view of the fact that he had evidence of pan-hyperpituitarism, a diagnosis was made accordingly. and the endocrine confirmed that the prolonged the synaptin test was positive because of, again, adrenal stimulation. So CT confirmed absent pituitary, and hydrocortisone treatment helped resolve most of the problems. So in terms of the literature review, which I did with the help of my brother, who translated quite a few of the papers that were in French, Spanish and German, we found, going back to the time of Thomas Addison, about 50 cases in total. 30 of those cases were of hypoadrenalism, 20 of the cases were of hypoadrenalism secondary to hypopituitarism. In terms of the hypoadrenal and hypopituitary group, the male to female ratios are actually relatively equal, despite which is at odds with what's coming up to date in terms of the female predominance. Age range was there with the cases 20 to 69, including the cases that we had for the hypoadrenal group, for the hypopituitary group 37 to 80. Apologies for not doing the mean and medians on those. The main clinical signs to be aware of, and these are probably, you think, very non-specific signs in these patients, but of myalgia, arthralgia and lower back pain. Those are the main symptoms those patients had in general. Those are the main things we found from going through all the literature. These are the common thread with all these patients. And the main sign was of flexion contractures. Obviously, with myalgia and arthralgia, we need to rule out other causes that may be going on, because as you know very well now from recent literature, as another, in terms of ultrasound and MRI picks up subclinical inflammatory arthritis these days. So clinical examination may not be entirely effective in picking these things up. So certainly now we have to look out for inflammatory arthritis, PMR, OA, as already mentioned, muscle disease as well in this patient group. So basically it's literally a diagnosis of exclusion. Lower back pain, again, ruling out other causes. So a good history is important to rule out a mechanical cause and check for inflammatory causes as well. And as well as if it's red flag back pain with constant back pain and it's particularly tender of the spine, think of infiltrative and infective causes as well. An MRI scan is very helpful. Right. So in terms of the clinical suspicion with when I say primary hypoadrenal patients, I mean that in this respect to the fact the actual hypoadrenal gland is only affected, the adrenal gland is only affected. So really the main symptoms these patients have really are GI symptoms of nausea and vomiting, weight loss and diarrhea, hypotension and hyperpigmentation. Those are the main symptoms that are listed in addition. Whereas a hypopituitary patient, interestingly, it's hypogonadism predominates in that group to suspect that. So lab tests, obviously, as we know, in any medical textbook, it tells us, so hyponatremia, hypokalemia, patients can get hypoglycemia, eosinophilia, anemia of sorts, occasional hypocalcemia, moderate elevation of TSH, autoantibodies, and in our studies, in our 2 patients, there were LFTs were abnormal. So investigation of choice is the ATM cortisol, followed by ideally an ACTH test. I don't think many of us have access to that. I think it's just the ATM cortisol, which is cost effective. And then a synaptin test and a prolonged synaptin test. Hydrocortisone for hypoadrenalism and hydrocortisone initially, followed by thyroxine for panhypopituitarism, for the simple reason is that obviously we don't want to get an adrenal crisis by giving them together when they haven't got any adrenal reserve or any steroids on board. So interesting case facts is until after 1950 that the patients in these case series actually started surviving, and that was a reflection due to the introduction of steroids into the cases. So from 1955 onwards, and when you look at the paper, you'll notice that patients begin to survive, and survival improves. An interesting case fact is the Muirhead regime, which I thought was quite an experiment with Dr. Roundtree on Professor Muirhead, and basically he tried all various things with this gentleman, including the rather painful, in those days, this is back in the 1920s, the big needle rectal injections of whole dried adrenal gland. And obviously the rectum will have absorbed that very, very quickly. It makes me feel uncomfortable just sitting around reading that. And essentially, obviously, found out that the depot injection has worked much better than any of the other things they tried for treating this gentleman. So we have a better idea now of how to suspect it. Obviously, it's still a diagnosis of exclusion. In terms of the flexion contractures, it's probably related to the ATP-ADP cycle, and that's why contractures develop, because cortisol plays a role in ATP regeneration. There's just a few facts about what we see in chronic disease. I haven't referenced those, but those are fairly well-known facts in terms of the association with the suboptimal adrenal response. So take-home message is that hypoadrenalism is relatively underdiagnosed. Still, although you may tell me otherwise, signs and symptoms can be subtle. Should be considered as a diagnosis of exclusion. Myalgia, arthralgia, etc. are the main symptoms. Flexion contractures are the main sign, especially low back pain as well. And ATM cortisol is a thing to do if you suspect it, and then short and long-acting tests. And in developing world, TB should still be considered as the primary cause. And obviously in developed world, autoimmune causes predominate. Obviously those who have a low socioeconomic class may be more TB should still be suspected in that group. So thank you for you people. My brother, who was upset with me for not putting him on the paper as an author because he'd actually contributed quite a lot in translating the papers. I did say a thank you at the end, but anyway, my mum wasn't very happy. Clinical Rheumatology for publishing it. Northwest Rheumatology Club because it won a prize, regional prize for the presentation. And the authors who contributed, particularly Dr. Chattopadhyay, who kept encouraging me to get this published because obviously then I'll be one of the few guys in the world who know anything about this. So anyway, I hope that was a useful talk and points to ponder from a clinical perspective. Thank you. Any questions?